Welcome back, Health Impact audience. We've got a power pack next hour or so with a special guest, and a super special guest, because what we've seen over the last 6 months, especially post-COVID, is that there's a lot of discussion about telehealth, innovation, and how a whole bunch of new ideas can improve the patient and doctor experience. It can improve our ability for health systems to do better care delivery. But we can't do that unless we actually have good, solid regulations, reimbursement, and other things from the CMS side. So the CMS Centers for Medicare and Medicaid Services. We've got Dr. Barry Marx here to talk to us about some of the upcoming rules that are going to be coming out in 2021 related to telehealth reimbursement and payment side of the conversation. He's going to talk to us a little bit about what the new rules that are coming out, which are currently in the comment period, have in them in a short presentation. And what you want to do during this time is take as many notes as you can and be prepared to use those notes to give comments to CMS, because we're still in the open comment period during the Health Impact sessions here. And you don't get to complain next year if you don't see something in the rules and you did not put any comments in. So Barry's going to do a quick presentation, then we'll come back and ask some questions, and then of course we'll open the questions up for the audience to ask live as well right after that presentation. So what we're seeing is in the last few months especially, we've seen an upheaval in certain cases. We've seen a continuation in certain cases, but everybody keeps saying, I can do a lot of innovation if only CMS would do X. And so the X is what, of course, Barry will be talking about here. So Barry is currently the director of the Office of Clinician Engagement at the Center for Clinical Standards and Quality at CMS. And he's going to help talk to us about what are the current regulatory challenges and changes going forward, coming together to remove these barriers. Dr. Marx currently serves as a director there, but he really comes to CMS from the Department of Defense, most recently as the chief of primary care of the Kirk U.S. Army Health Clinic at the Aberdeen Proving Ground. Everything with the military sounds cool, right? The Aberdeen Proving Ground. That seems a very nice place to work. Prior to working at the DoD, Dr. Marx was a senior medical advisor to the Office of Head Start, and he's worked in the FQHC community, the federally qualified health centers community, for more than a couple of decades. So he's got a lot of experience out in the field. So this is not a person who sat in an ivory tower making rules for everybody else and then hoping that it matters. He's been out there, and which is why we want you guys to take this opportunity to really ask good, solid, pointed questions about what he's going to present as far as the rules are concerned. But beware, currently, the rules are open for in the request for comment period, so he may not be able to answer things that that you want answered in a way that you want answered. The only answers he can provide are what the text says today. He can't add his opinion to it. He can't add his ability to say, hey, I wish I could do X, Y, and Z. So the questions you want to ask should be tied to his presentation, and then you'll get really crisp, clean answers. Otherwise, he'll just tell you, sorry, can't answer that because they're in the request for comment period. With that introduction, it is both a pleasure and an honor to have you here, Barry. Please tell us a little bit about yourself, and then we'll jump into your presentation and then for the follow-up questions.
Well, Shahid, thank you very much for that introduction. And once again, my name is Barry Marx. I'm the director of the Office of Clinician Engagement for CMS. I am by training a pediatrician, subspecialty trained in pediatric endocrinology and diabetes. And as a medical officer at CMS, I also continue in active clinical practice. And so once a week, I continue to see children of active duty and retired military personnel in the clinic at Aberdeen Proving Ground. The invitation to speak to you today to discuss the extraordinary expansion in virtual health in the circumstances of the COVID-19 public health emergency and CMS's role in that expansion comes at a particularly significant time. As you mentioned a few moments ago, CMS recently issued the calendar year 2021 physician fee schedule proposed rule. and we are still in the public comment period. It's important to be aware that the proposed rule includes proposed changes that are not reviewed in this presentation today, and I urge you to refer to the proposed rule for more complete information. Feedback during this presentation is not considered as formal comments on the proposed rule. So as questions, comments, and recommendations occur to you, I would urge you to submit these through the formal public comment process for consideration. Next slide. I'm first going to provide an overview of how Medicare pays for services that utilize communication technology prior to the public health emergency. First off, I want to flag that the presentation will only cover Medicare payment for professional services. Services that utilize communication technology may be paid differently under different payment systems or settings of care, like home health and hospice. And what I will be covering today does not pertain to those settings. The term telehealth is frequently used alongside terms like telemedicine to describe a range of virtual services, from those meant to take the place of in-person services to things like remote physiological monitoring or e-visits. I'll cover those sorts of services later in this presentation, but for purposes of our discussion today, Medicare Telehealth has a very specific meaning. Section 1834M of the Social Security Act lays out the specific circumstances where Medicare will make payment for services that would otherwise occur in person, but instead are furnished via communication technology. The beneficiary must be in a rural area and in a medical facility, so not in their home. There are a few exceptions. Congress has amended Section 1834M to remove the geographic and site of service restrictions for beneficiaries with end-stage renal disease, for diagnosis and treatment of acute stroke, and for beneficiaries with a substance use disorder and co-occurring mental health disorder. The statute also limits the type of practitioners who may bill for services delivered via telehealth. There's actually a list of eligible practitioners as described in the statute. The statute specifies that the technology must be synchronous, which we have a long-standing regulatory interpretation of as two-way audio-video telecommunications technology. There are exceptions for asynchronous or store and forward communication technology, but those are limited to federal telemedicine demonstration projects in Alaska and Hawaii. With a few exceptions, Medicare telehealth services are existing CPT codes and not codes valued specifically as remote services. A list of these codes is maintained on the CMS website, and every year CMS considers public requests and at times has conducted an internal review to determine if there are other services that should be on the telehealth list. This process is conducted through the physician fee schedule notice and comment rulemaking process, which I will discuss in more detail in a bit. In certain circumstances, CMS has created Medicare-specific coding to describe a portion of a service when we do not believe that the full service could be furnished via two-way audio-video communication technology. For example, we've received public requests to add the CPT codes describing critical care to the telehealth list. While in the past we've articulated that we did not believe the full scope of service elements described by those CPT codes could be furnished remotely and instead would require a hands-on, in-person interaction, we did create Medicare-specific coding to describe a consultation service delivered when a patient was in the critical care setting. The Medicare telehealth benefit, as described by 1834M, was written over 20 years ago and was meant to incentivize the provision of services remotely to patients in rural areas. It was not designed to keep up with advances in technology or the evolution of virtual care. Next slide, please. It should be noted that Medicare Telehealth is not the only way Medicare pays for remote services. Medicare has a long-standing policy of paying for remote interpretation of diagnostic tests and for care management services, both of which may use communication technology to fulfill the elements of the service. In recent years, we have also begun making payment for what we call communication technology-based services. These services, like the virtual check-in, remote monitoring, and e-visit, are not meant to take the place of an in-person service like Medicare telehealth services are. These services are not in-person services at all, and in fact are meant to prevent an in-person visit. They also pay less than similar telehealth services, and are not subject to all of the telehealth restrictions. What I just described was the state of Medicare payment for virtual care prior to the public health emergency. In the circumstances of the COVID-19 public health emergency, to reduce exposure risk, CMS moved quickly to expand access to telehealth and other kinds of virtual services. To put this in context, in the week before the declared public health emergency, only 14,000 patients received a Medicare telehealth service. During the public health emergency, from mid-March through early July, over 10.1 million patients received a Medicare telehealth service. In order to expand access to telehealth use, we used a combination of statutory waivers and regulatory authority. Using waiver authority, we removed the restrictions in the statute surrounding where the beneficiary must be located. Now beneficiaries in rural and urban areas can receive telehealth services, and also the beneficiary can remain in their home. We waived the list of practitioners defined in statute to allow additional types of providers to offer telehealth services during the public health emergency. We also waived the requirement that the technology be two-way audio-video for a subset of counseling and education services. As the waiver authority used to remove these restrictions is tied to the duration of the public health emergency for COVID-19, these flexibilities will terminate with the public health emergency. As these are statutory restrictions, to make any of these flexibilities permanent will require an act of Congress. As a companion to these waivers, we undertook emergency rulemaking to remove any remaining regulatory hurdles. There were two interim final rules, the first published in late March and the second in early May. These are temporary policies that will expire at the end of the public health emergency. CMS expanded the range of services that can be furnished as telehealth by adding approximately 135 new services to the Medicare telehealth list. These included a range of services from emergency department visits to certain physical or occupational therapy services. For certain services, such as subsequent nursing facility visits and subsequent in-person visits, outside of the public health emergency, there are restrictions about how frequently these services can be provided as telehealth. For nursing facility visits, only one visit every 30 days can be a telehealth visit, whereas for inpatient services, only one visit every 3 days. The idea behind these limitations is that these are vulnerable populations, and we wanted to ensure that they were receiving adequate in-person care and not being seen entirely by telehealth. However, under the circumstances of the public health emergency, we believe that reducing exposure risk is of paramount importance. And so we are allowing visits in these settings to be provided as telehealth without limitations on frequency. I want to speak specifically about audio-only services. While I mentioned that we waived the technological restrictions for certain behavioral health and counseling services on the Medicare Telehealth list, we also began paying for audio-only telephone visits. We heard from the community that some patients, particularly patients in the Medicare population, did not have access to or would prefer not to use audio-video communication technology, and that because of this, practitioners were using the audio-only codes as stand-ins for office visits in certain circumstances. Since the audio-only visits pay significantly less than an office visit, this was creating a disruption in revenue for practitioners who used to only provide office visits. And this may have had an impact on access to care. Therefore, we increased the payment rates for these audio visits to help ensure that access was preserved for this vulnerable population. Alongside all of the related flexibilities that I just described, we have updates to Medicare Telehealth and other virtual services through the standard physician fee schedule rule. As I mentioned earlier, flexibilities around geography, site of service, practitioner type, and technology would require an act of Congress to make permanent. For those flexibilities that were implemented through rulemaking, CMS does have the ability to make some or all of them permanent. The proposals in the physician fee schedule represent CMS's preliminary assessment of what flexibilities should remain permanent, and we're very much looking forward to the public comments. These proposals should very much be taken as our initial thoughts and are subject to change as we receive information from the public through the comment process. The slides that follow describe services that CMS is proposing to permanently or temporarily add to the Medicare Telehealth list, as well as services we are not proposing to add on either a permanent or temporary basis. I'd like to briefly review the process through which services may be added to the Medicare Telehealth list prior to the COVID-19 public health emergency. In the calendar year 2003 Physician Fee Schedule final rule with comment period, we established a process for adding services to or deleting services from the Medicare Telehealth Services list in accordance with 1834M of the Act. This process provides the public with an ongoing opportunity to submit requests for adding services, which are then reviewed by CMS. Under this process, we assign any submitted request to add to the Medicare Telehealth list to one of two of the following two categories. Category 1 are services that are similar to professional consultations, office visits, and office psychiatry services that are currently on the Medicare Telehealth Services list. In reviewing these requests, we look for similarities between the requested and existing telehealth services for the roles of and interactions among the beneficiary, the physician or other practitioner at the distance site, and if necessary, the telepresenter, a practitioner who is present with the beneficiary in the originating site. We also look for similarities in the telecommunication systems used to deliver the service. For example, the use of interactive audio and video equipment. Category 2 services are services that are not similar to those on the current Medicare Telehealth Services list. Our review of these requests includes an assessment of whether the service is accurately described by the corresponding code when furnished via telehealth, and whether the use of a telecommunications system to furnish the service produces demonstrated clinical benefit to the patient. Submitted evidence should include both a description of relevant clinical studies that demonstrate the service furnished by telehealth to a Medicare beneficiary improves the diagnosis or treatment of an illness or injury and improves the functioning of a malformed body part, including dates and findings, and a list and copies of published peer-reviewed articles relevant to the service when furnished by telehealth. Our evidentiary standard of clinical benefit does not include minor or incidental benefits. For examples of clinical benefit, I would direct you to the calendar year 2021 physician fee schedule proposed rule. This slide describes Medicare Telehealth Proposals that we propose adding as permanent to the Medicare Telehealth Services list. For our calendar year 2021, we're proposing to add a number of services to the Medicare Telehealth list permanently. These include lower-level established patient home and/or domiciliary visits, and assessment and care planning for patients with cognitive impairment, group psychotherapy, and 2 add-on codes associated with our previously finalized office outpatient E&M policies. We spoke earlier about Category 1 and Category 2, Medicare Telehealth Services. We are proposing to create a third temporary category of criteria for adding services to the list of Medicare Telehealth Services. This new category, Category 3, describes services added to the Medicare Telehealth list during the public health emergency that will remain on the list through the calendar year in which the public health emergency ends. This will also give the community time to consider whether these services should be delivered permanently through telehealth outside of the public health emergency. These services, as shown on this slide, we are proposing to add to the telehealth list on a Category 3 basis and include lower-level emergency department visits, higher-level established patient home and domiciliary visits, certain psychological testing services, and nursing facility discharge day management. Slides 8 and 9 that follow show services that we are soliciting comment on. These are services that were added to the Medicare Telehealth list during the public health emergency for COVID-19 that CMS is not proposing to add to the Medicare Telehealth list permanently or proposing to add temporarily on a Category 3 basis. For our communication technology-based services, we're clarifying who can bill for e-visits, and this includes licensed clinical social workers, clinical psychologists, physical and occupational therapists, and speech-language pathologists. We're also proposing to allow these practitioners to bill for the virtual check-in and remote asynchronous service. Even prior to the public health emergency, stakeholders have stated that the once every 30-day frequency limitation for subsequent nursing facility visits furnished via Medicare Telehealth provides unnecessary burden and limits access to care for Medicare beneficiaries in this setting. Therefore, we propose to revise the frequency limitation from 1 visit every 30 days to 1 visit every 3 days. We also seek comment on whether these policy changes will enhance patient access to care if we were to remove frequency limitations altogether, and how best to ensure that patients continue to receive necessary in-person care. In recent years, CMS has finalized payment for remote physiologic monitoring codes. In response to stakeholder questions about remote physiologic monitoring, we are clarifying in this proposed rule our payment policies related to the RPM services described by CPT codes 99453, 99454, 99091, 99457, and 99458. In addition, we are proposing as permanent policy 2 clarifications to RPM services that we finalized in response to the public health emergency for the COVID-19 pandemic. We are proposing as permanent policy to allow auxiliary personnel to furnish certain remote monitoring services under a physician's supervision. Auxiliary personnel can include contracted employees. We are clarifying that the medical device supplied to a patient as part of a remote monitoring service must be a medical device as defined by Section 201H of the Federal Food, Drug, and Cosmetic Act, that the device must be reliable and valid, and that the data must be electronically, that is, automatically, collected and transmitted rather than self-reported. Medicare has previously considered that when a service is furnished under direct supervision, the practitioner supervising and subsequently billing for the service must be on site. And while they don't need to be in the room, they do need to be in the facility where the service is being furnished and available instantly. For the duration of the public health emergency, we adopted an interim final policy revising the definition of direct supervision to include virtual presence of the supervising physician or practitioner using interactive audio-video real-time communications technology. We are proposing to continue this policy up through the end of the calendar year in which the public health emergency ends, or December 31st, 2021, whichever is later. We are seeking information from commenters whether there should be any guardrails in effect as we finalize this policy through December 31st, 2021, or the end of the public health emergency, or whether we should consider adopting this policy on a permanent basis and what risks this policy might introduce to beneficiaries as they receive care from practitioners under remote supervision. This takes me to the end of my presentation. I'd like to take a moment and just discuss when and where to submit comments during the public comment period. I would urge you to see the proposed rule for information on submitting formal comments. The formal comment period closes on October 5th, 2020. Again, bear in mind the proposed rule includes proposed changes that were not reviewed in this presentation, and I would urge you to refer to the proposed rule for complete information. Feedback presented during this presentation may not be considered as formal comments. And again, I urge you to please submit your comments using the formal process.
All right, that was great, Dr. Barry Marx. So we definitely appreciate you running through that with us. And as we open up our lines for comments coming in and asking questions, let me start off with a couple, having been part of processes for reviews and requests for comments in the past. There are always things that CMS likes to see in comments. Could you provide a little bit of color around what are the kind of comments that come from the community that are most helpful to regulatory personnel versus those that might be less helpful and more difficult to manage as far as the comment period is concerned? So when things come in, what are the things you'd like to see? Is there evidence that you like to see? Is there reference material that you like to see? What are the kind of things that you like to see in the comments?
Thank you, Shahid, for that question. There are no specific requirements regarding comments. Obviously, it is an open comment period, and the agency welcomes any and all comments. If there is a view towards comments that are to be actioned by the agency, obviously, the more detail that can be provided, the more actionable that comment may be. But again, we welcome any and all.
Yeah, that sounds great. And when you think about other ways that the community can help, you've asked for very specific comments in the comment period. Are there other ways, especially in the COVID environment when data is very difficult to get access to, and you're doing the best you can at CMS to work with the communities? Are there other ways that the community can help CMS besides just the comment period going forward?
I think that as an agency, we are always open to feedback from stakeholders, even outside of a formal comment period related to rulemaking. And so again, as particularly participants in this conference have knowledge, experiences, and what could possibly be considered as best practices, I would certainly urge you to share those.
Yeah, that's great. And the reason why I wanted to ask that question and have you actually state that is there are a lot of folks in the community that believe that the government is not open to hearing. Certainly, the fact that you're asking for open period is good. But even outside of these, unsolicited proposals, unsolicited comments are often welcomed throughout the year. And there's a lot going on in the government at the moment. Everybody there is busy, working long hours, trying to get the rules and regulations so that COVID-19 can be handled as best as possible during the public health emergency. One of the things you mentioned a couple of times in the presentation was this difference between statutory and regulatory. So you and I probably know that in some level of detail. Could you tell the audience why are there certain things that you are not allowed to do at CMS that are sitting in statutes, and why does it require an act of Congress versus other things that you are able to do because they're in regulatory language, et cetera? Just a process question would be helpful for the audience.
Understood. So the reference to statutory authority refers to authority that CMS as an agency is granted by the law. And so changes to statutory authority would need to be executed through that same mechanism, which again would be act of Congress. CMS has regulatory authority. And in those areas, as I mentioned earlier in the presentation, CMS does have some ability. And as an example of that, the process that we're undertaking right now with the public comment period for the proposed rule is an example of that type of flexibility, if you will, that the agency has around regulation.
Excellent. And are there areas of the rulemaking that were more difficult to think about because evidence doesn't exist? So when you look at things like clinical benefit and you think about what Medicare is willing to pay for or not willing to pay for, without mentioning what's in the rule itself, how do you ascertain the kinds of things that would be clinical benefit? Are these things that are already written and available in statutes and regulations before you made these rules? Or have you guys come up with new things that you've put into the rules that weren't available before because COVID has highlighted or shown some things as far as clinical benefits and others that have come by?
Yeah, that's a wonderful question. And I think that that's probably most readily answered with reference back to what we described as Category 2 potential telehealth services, which are telehealth services that are not similar to existing telehealth services and that therefore require a review of available evidence. And again, I would direct participants back to the actual text of the calendar year 2021 physician fee schedule proposed rule for a very detailed description of Category 2 and what the evidence to support those submissions would be.
Excellent. No, that's terrific. And Dr. Barry Marx, we definitely appreciate you being here, and we're Dr. Barry Marx, we definitely appreciate you being here, and we're opening the questions. The questions have already been coming in, and we're opening it now to have you and your colleagues answer to the best of your ability that you can do in an open comment period. So with that, we appreciate it, and we'll turn you over to the audience.
Thank you very much.
Please, anybody else who has answers to these questions, you can jump on. We can go live and have a impromptu session while we're waiting for Barry to join us. Now, to the question that I think it was Kim asked, are RNs, LPNs, et cetera, eligible for RPM reimbursement? Generically speaking, the answer is an unqualified yes, right? Unqualified because you have to look at which CPT codes you're talking about. So if the remote patient monitoring that you're doing is tied to a CPT code, there are some CPT codes, for example, that do allow Kim, even unlicensed therapists to participate and get reimbursed for. So yes, in general, there is participation allowed and reimbursement allowed for RPM for RNs and LPNs as we see it. But to be much more specific, you'd have to actually look at there's about a dozen or so HCPCS as well as CPT codes that Barry mentioned in his talk. Excellent. So Barry, are you there?
Thank you very much. Unanticipated technical issues here, but really, again, delighted to have been invited to present and happy to be on for the remaining few minutes.
No, that's fantastic, Barry. We appreciate it. I know you've been trying to do this for the last half hour on a government computer, so we appreciate you giving it a shot. So we have one question from the audience that we'd love to get your thoughts on. Kim asks, are registered nurses, LPNs, and related clinicians eligible for remote patient monitoring reimbursement?
Yeah, and for that information, there are a number of resources that the agency has actually put out. And recall that there have been a number of waivers and flexibilities enacted through the various interim final rules with comments, as well as what's in the 2021 proposed physician fee schedule rule. And so for the most current answer to that, I would direct questioners to those resources. And all of those are available on the CMS website.
Got it. Okay, great. So when you think, could you talk a little bit more about how long the comment period is now open, and then the amount of time that it will be in the comment period? Just guessing, so that we can see when these rules will likely become more than proposed rules, but accepted rules.
Yeah. So first of all, the open public comment period is open through October the 5th. And in that regard, the invitation for this speaking opportunity really comes at an extraordinarily significant time in the context of the question of what can we do. This is exactly what the process is designed for. This is exactly what the open public comment period is designed for. And I would strongly encourage anyone in your listening audience with questions, comments, suggestions, recommendations to the agency to please go in and submit those through the formal public comment process. The other point I would make is that if you look at the notice that's posted in the Federal Register, the subject matter experts for specific elements of the proposed rule are actually identified. And so if there are questions that one of your participants would need to have addressed in order for them to then formulate and submit their comment, those people are actually identified in the Federal Register posting. And so I would certainly encourage folks to reach out. Following the closing of the public comment period, obviously, that's been the time where the agency reviews the public comments and formulates what will go forward as a final rule, that process. And to be honest, I don't know exactly when the deliverable is on that, but usually it's a process that takes a number of weeks afterwards. so hopefully this is helpful content. But again, I really want to emphasize that this is the opportunity for your listeners to really have a substantive impact on how this goes forward through the public comment period.
Yeah, that's a great advice, Barry. So another follow-up question from Kim is there a bill that you are aware of before Congress to make the public health emergency telemedicine measures more permanent? If you're aware of any, just let us know. If you can't speak about it, that's okay too.
Yeah, and there's, I think, a lot of interest in this. There's no specific bill that I can reference or that I have particular insight into.
Fair enough. And so one of the items you mentioned at the beginning of your talk was about the distinction between the changes to direct supervision via telehealth and the incident to billing. Can you just kind of like say, elaborate on that a little bit? What do you think is, based in the proposed rule, what is the biggest difference to direct supervision and incident to billing that our audience can listen to and then provide comments about?
Yeah, so that's a wonderful question. And again, for the most substantive and authoritative response, I would direct your listeners to the actual posted notice of proposed rulemaking for that section. That is the most current and authoritative source of information on that, including where the opportunity is through the proposed rule.
Got it. And so for the audience, this is me adding color commentary, not coming from Barry. But if I were you guys, I would pay very, very special attention to that area because it is literally, in my opinion, one of the biggest changes, which is this rule for direct supervision and the incident to billing, because there are now new approaches that you can take for improved reimbursement, for things that you weren't able to reimburse for before. So to take Barry's advice, definitely pay some very specific attention to those particular areas. And then, the removal of the frequency limitations, I think, was another big thing that Barry mentioned in his talk. And so these are more for the post-acute environment audience members, as if you're in post-acute care, you've got a lot of new things that are coming up in terms of nursing facility limitations being lifted and hospital inpatient services being lifted. So those are pretty important to seek out and figure out whether or not you want to comment on that. So with that, Barry, we want to say thank you for joining us and for giving us the presentation. And our audience is now going to be moving on to our next session. So with that, we'll sign off on this session. Please go to your agenda, click on the next session to join there.
Thank you very much.
Thank you, Barry. Thank you, everybody on the audience, and we'll see you in the other session.